surgery endocrine section. Today, we will discuss the variety of dedifferentiated thyroid cancer, ranging from aggressive differentiated variants, medullary thyroid cancer, and anaplastic thyroid cancer. I'm Nishant Agrawal from the University of Chicago. I want to thank the co-organizers, Michael Singer from Henry Ford, Brendan Stack from Southern Illinois University, and our leader, Greg Randolph from the Mass Eye and Ear. I also want to encourage you to join the American Head and Neck Society. It is the single largest organization in North America for the advancement of research and education in head and neck oncology, with over 1,700 members, including 600 members of the endocrine surgery section. And one other benefit is Greg Randolph friends you on all your social media. So many benefits of joining AHNS. At the end of our webinar, you will receive an email to claim your CME, so please do that. I want to introduce our discussants, Dr. Yuri Nikiforov from the Department of Pathology at the University of Pittsburgh, Dr. Brian McIver from Endocrine Oncology at the Moffitt Cancer Center, and Dr. Mark Zaffario from the Department of Head and Neck Surgery at MD Anderson. These are their disclosures. So we have 3 cases today, and we'll begin with Dr. John Russell from Johns Hopkins. John will present a case on aggressive differentiated thyroid carcinoma.
Thanks, Nishant, and thanks to the AHNS for the chance to be here tonight and to share with you. Great honor, certainly. So I'm John Russell. I'm from Johns Hopkins Hospital, and I'll be talking about differentiated thyroid carcinoma in an aggressive variant. This is a gentleman that presented to my clinic a few years ago, a 66-year-old gentleman who felt like he had gotten hit by a rock while he was mowing his lawn and had noticed that he had some swelling in his chest. And he thought that it would get better, and it never got better, and it went on for a year and then a little bit longer. And eventually he went to see his doctor and was noted to have a chest mass, just kind of right at the top of his sternum. He had a history, by the time I saw him, of about 6 months of progressive dyspnea and a much more recent history of hemoptysis. When I saw him, he had recently undergone an open chest wall biopsy at an outside hospital who had gone in planning to resect this mass. This is the imaging that he came with. When I looked at him, and I'll show you a couple of extra slides as we look on, but when I saw him, of course, I appreciated this mass that really started at his manubrium and extended north just a little bit. It was very much fixed. His right thyroid was fixed and continuous with this mass. And you can see that there was a 5-centimeter isthmus mass that kind of went down into this 10-centimeter manubrial mass. On flexible, and I'll show you, this is up a little bit higher, closer to his thyroid and that isthmus mass. On flexible fiber optic laryngoscopy, he did have evidence of an intraluminal or intratracheal mass. And when we did biopsies of the neck disease on both sides of his neck, this showed papillary thyroid carcinoma.
So, John, I just want to interrupt for 1 second. So, Mark, I want to ask you a few questions. So based on this, Mark, you're the surgeon discussant. What are your thoughts on this? And what additional imaging or workup would you consider?
Good evening. This is a tough case. So from my understanding, this gentleman has had obviously ultrasound CT imaging. He has a diagnosis of papillary thyroid cancer. I think with this degree of aggressiveness, biologically aggressive behavior from this tumor, I'd probably want to send the tumor for some genetic molecular mutations. Not that would definitely change the management, but it could. I mean, if you could offer this patient some type of upfront targeted therapy, but I mean, given the dyspnea and that, and you know, the presenting symptom, it's probably unlikely, probably more likely to want to start with surgery. But the other thing you may consider is a PET scan. You know, a lot of these thyroid cancers are not PET avid, obviously. Most are not, but these biologically aggressive cancers, oftentimes they can be PET avid. So, given that the patient already, I didn't understand if this manubrial mass was a met to the manubrium or was it direct invasion. But he obviously would be at high risk to have other distant metastasis as well. So, you know, CT of his neck and chest, I'm sure was already done, but maybe a PET scan as well.
Yeah, thanks, Mark. I think there's a couple of great points. I want to tackle one of them about molecular pathology. Yuri, so if you received the open biopsy of the chest wall mass, which demonstrated thyroid carcinoma, what would you do with that? Would you do molecular testing at this point to help define the degree of dedifferentiation in addition to the histologic analysis that you perform?
Hello, everybody. This is Yuri. Yeah, these are good questions, and Mark pointed out already. I want to say that from pure pathological perspective, I don't think that we would need molecular testing to define different level of differentiation. But to the point that Mark brought up before, I mean, thinking about neoadjuvant setting, I think that definitely we typically this highly aggressive tumor, we are trying to do molecular testing as early as possible to really see what other therapeutic options that can be available for this patient.
So John, a couple questions back to you. Did you consider molecular testing prior to surgery? Was a PET scan or systemic imaging performed? And then as Mark brought up, did you guys consider local extension versus mets to the bone as a differentiation, as a differential?
Yes, to all of those. We did get a PET scan, and the PET scan showed, of course, that this was FDG avid throughout and had multiple metastases throughout his body, especially to his lungs, but also to other. He had one in his axilla actually as well. Yes, we did consider, and we actually sent the molecular markers off of that open biopsy that had been done. That for us, that takes a little while until we can get that turned around, and we did not delay our surgical intervention given the extent of his symptoms at that time. And given that we did think that this was resectable. With regards to whether or not this was continuous versus if it was a metastasis, it's sometimes hard to tell when you've got a big isthmus mass and a big manubrial mass. It seemed to be that they were contiguous. Nevertheless, if you look at the borders on some of the cuts, it seemed like they became gradually less or more irregular as you proceeded inferiorly. And so kind of I still don't know for sure which it was. It was all contiguous, certainly, but I don't know if it was a metastasis that then grew, or hard to say.
And for the group, would anyone consider diagnostic and endoscopic procedures such as bronchoscopy, esophagoscopy to define sort of the extent of invasion? There's a question in chat about the length of tracheal invasion. So did you consider that at all, John? Esophagoscopy, bronchoscopy as a stage to exactly figure out what surgery would be necessary?
We did not consider it staged based on the quality of our imaging, and he was actually quite a good, we injected local anesthesia directly into the lumen of his airway in the office, and we got a fairly good bronchoscopy in the office itself, where we were able to evaluate that he had a fairly focal defect. We felt confident that that would be amenable to a tracheal resection and reanastomosis. We did begin our case in the operating room with an esophagoscopy to evaluate for invasion as well, but we did not stage that.
Brian, one question for you before we move on. So in the setting of distant metastatic disease, what's your goal of care here? And do you try to control this local regionally, or do you start with systemic treatment or some sort of neoadjuvant treatment? Brian?
So let me say from the outset that this is the kind of patient that we need to start thinking like oncologists about rather than thinking as endocrinologists and surgeons about. This is incurable disease by local regional therapy. Unfortunately, of course, we don't have clinical trial data yet to demonstrate that neoadjuvant therapy is going to be beneficial, but this is an individual who should be submitted to a clinical trial if any such clinical trial is available. And I think that where clinical trials are not available, we need to try to make them available. These unfortunately are rare individuals, but this is aggressive, invasive, and incurable disease by our current criteria. So what approach can we realistically take? I think we need to recognize that protecting his airway is key, and there's a surgical component of that. Whether it's worth doing more aggressive surgery or turning to external beam radiation therapy of some sort, whether that's protons or IMRT, I think we need to include that in our conversation. But to me, at least, the central issue here is what are the mutational drivers? Realistically, this is going to be papillary thyroid cancer. It's likely to be BRAF positive. It's likely to be some other mutation like TERT or P53. And increasingly in the future, these are going to be targetable mutations that may lend themselves to neoadjuvant therapy and perhaps get this patient to the point where we can effectively manage the local regional disease, at least after we've used systemic therapy. But right now we're in a data void, and so clinical trials are really key.
John, sorry, go ahead, please, with your presentation.
Yeah, thanks for the comment. So in the operating room, we did do a direct laryngoscopy, again, tracheoscopy, esophagoscopy, and then did a total thyroidectomy, central neck dissection, lateral neck dissection, sternal resection, including down to the fourth rib, tracheal resection, and reanastomosis. Intraoperatively, we were able to clear the distal tracheal margin, the proximal cricoid margin. As we shaved back through about the bottom half of the cricoid, we were still encountering positive margins at that point. Rather than thinking exactly like what Dr. McIver had just stated, rather than moving forward with a total laryngectomy, we felt that it was more appropriate to leave that microscopically positive margin. He was ultimately reconstructed with bilateral pec flaps and then ended up needing additional tissue and had an ALT for the reconstruction. This is the final product of the reconstruction. Postoperatively, the final pathology demonstrated columnar cell variant of papillary thyroid carcinoma, and the manubrial component was poorly differentiated. It was BRAF V600E positive and also TERT promoter positive as well. He did not have any extranodal extension on any of the lymph nodes throughout his neck or anything that we took out.
So,
Interestingly,
yeah, 1 second, John. So Yuri, what are your thoughts on this pathology? And I think Lisa Orloff asked a very good question. So although this is a very aggressive cancer, it was recognized as papillary thyroid cancer. How do you determine the difference between very late presentation versus something that's biologically more aggressive? Yuri, your thoughts on that?
Yeah, very good point. Well, we know that columnar cell variant of PTC is one of the most aggressive variants. So that's one of those situations when the tumor morphologically presents as a well-differentiated. We see, still papillary structures, we see nuclear, we see cytoplasm. It's not solid sheets, there is no necrosis. But by virtue of such morphology, we know that in most cases, this is an aggressive type of papillary carcinoma. So in addition here, definitely there is a poorly differentiated component, which is very fitting this molecular profile, BRAF and TERT, because we know that these tumors are prone to dedifferentiation, and eventually probably at some point that would end up to be an anaplastic carcinoma, but not yet based on pathology.
Great. Go ahead, John. Sorry, please continue.
Interestingly, on his postoperative thyroid scan, he was noted to be radioactive iodine avid. And so he received 200 millicuries of radioactive iodine with a fairly robust response that persisted for about a year afterwards. More recently, he has started to have progression of distant disease, as mentioned in the axilla. He's got other bony metastases that so far have not been irradiated. and he was started on lenvatinib with an excellent response. He is currently alive and well with very slow progression. This is 3 years post-operatively at this point. Very slow progression of metastases, and he is being considered for a trial of Pembrol.
So Mark, one question. So with that positive margin, would you consider converting this to a total laryngectomy intraoperatively if you had counseled the patient that that was a possibility?
It's a good question, but yeah, as John, Dr. Russell had mentioned, I would not, because, you know, as was discussed also by Dr. McIver, I mean, this is an incurable disease. He has distant metastasis, so I don't think you should maximize the local therapy, you know, with morbidity by doing a laryngectomy in order to try to clear a microscopic margin. So I would have handled it exactly the same way. And then I think there was another question about the external beam radiation therapy, and I would see that in a similar way. I would not typically recommend external beam radiation therapy in such a case like this, because I feel like, you know, the treatment for this is really going to be systemic, you know, as was done with lenvatinib, and, you know, also there are other targeted agents, BRAF inhibitors and immunotherapy. So his distant disease is ultimately going to probably determine his survival. So in order not to maximize his local therapy, I think I would avoid, you know, a more morbid surgery and avoid external beam radiation.
Ryan, do you agree? Would you consider external beam radiation given this pathology in addition to radioactive iodine?
So my views on external beam have changed over the course of the 8 years that I've spent at Moffitt, because in part of the impact of Lou Harrison, who is our chair of the Department of Radiation Oncology. And as you know, Lou is you know, a world expert in radiation to the head and neck. I used to argue in endocrine audiences and surgical audiences that there was really almost no role for external beam radiation therapy in thyroid cancer, because it was harsh treatment in patients who had generally long-term survival prospects. I certainly changed my tune in that over the last few years, and I've realized that really there is a role for external beam radiation therapy, particularly when it's IMRT or proton therapy. But even so, we still use it very, very selectively. In this individual, you know, remarkably, you had a near total, it was an R1 resection with microscopic positive margins. And I agree that avoiding external beam radiation, reserving it for local regional recurrence would be appropriate here.
Great, thank you. And then Yuri, there's a question in the chat about, we keep mentioning molecular testing. What does that actually consist of? And Mike Singer asked this question, is that a company's off-the-shelf test or something else, an in-house panel?
You're on mute.
You're muted.
Sorry. Yeah, it can be either. There are obviously commercial offerings. I mean, Foundation Medicine, Tempus, several other companies offer large NGS panel. Definitely it has to be a large panel, because of the, you know, large next generation sequencing based panel, because this panels have practically all possible therapeutic markers. Obviously, we know that most of these tumors are BRAF positive, but you never know. It can be a fusion, it can be an TRK fusion, can be ALK fusion, who knows what else you can find. And most large institutions, they do have their own panels. I mean, obviously, most cancer centers by now have 300, 400, 500 gene panels, which also are very good. The point is that it has to be a comprehensive, it has to be a large panel. It cannot be just 2-3 genes, BRAF only or RAS only. It has to be 100+ gene panel to really be sure that it's a comprehensive characterization of such tumor.
Thank you. John, do you want to continue and finish up?
May I just make one quick statement that this question is very poignant, that Michael and others have made about molecular testing, and the Head and Neck Society is completing its work on a very detailed, comprehensive white paper that relates to this, that actually Yuri and Mark are both participating on, to address the circumstances of exactly what sort of testing is needed and exactly what are the definition of advanced disease, which has many different faces to it, that requires that testing. So the Head and Neck Society will be having that ready through the leadership of David Shanka in the next few months.
Thanks, Greg. Go ahead, John.
So in conclusion, the things that I took away from this case, I think sometimes we don't really stress the amount of bulk that you need to reconstruct the central neck, especially in the setting of a temporary tracheostomy where you have to protect those great vessels, the innominate, etc. We've talked already about the positive tracheal margin. I like the way that Dr. McIver stated, thinking like an oncologist rather than, must clear disease no matter what, because that distant disease is what's going to dictate the prognosis. And then kind of, certainly as we've alluded to already, we know that some combinations of mutations are certainly more aggressive than others. This is a paper from Dr. Xing, just looking at the BRAF and CHERT combination, leading to much worse survival overall. And of course, there's many other papers, many of which have been done by other panelists and members of this committee.
Brian, do you want to make a comment and we'll move on to the next case?
Yeah, my final comment again is a plea for us to collaboratively develop and recruit to relevant clinical trials. We've got evidence and FDA approval for the use of BRAF inhibitors in anaplastic thyroid cancer, not yet in traditional papillary thyroid cancer, but these poorly differentiated kind of spectrum disease cancers really deserve to have clinical trials developed around them. This would be an excellent individual to be a candidate for a BRAF inhibitor clinical trial, or as you're planning to, one of the Pembro or Nivo immunotherapy trials. The interesting thing about thyroid cancer is that it's often driven by a small number of mutations. The tumor mutational burden is relatively low, and so the neoantigen exposure is realistically going to be low. And I'm a little bit skeptical about how effective immunotherapy is going to be. So targeted therapy clinical trials are really going to be the key, I think, for progression in the treatment of these patients.
I'll just briefly mention that there is a neoadjuvant trial with lenvatinib for local regional advanced disease that's open at Mass General and Mass Eye and Ear, and we'll be opening at Memorial Sloan Kettering and MD Anderson in the next few months. And ITOG is also considering Mark's trial of a neoadjuvant therapy. So those that call for clinical trials in a neoadjuvant setting are being answered.
Well, thank you all for an illustrative case and discussion. So we'll now move to Dr. Peter Angelos from the University of Chicago to discuss a case on medullary thyroid cancer.
Thanks, Nishant, very much. It's a pleasure for me to be here and be part of this session today. And I have no disclosures. So this patient was a 43-year-old woman without prior medical problems who presented to her endocrinologist with complaints of a lump in her neck that she said was present for about a year. She had no pain and no difficulty breathing or swallowing. And her family history was negative for thyroid cancer, other cancers, or even any other endocrinologic problems. And she was euthyroid. So this is just sort of a representative shot of her ultrasound. And what you see is that she just has this large nodule there in the lobe. It was read as 4.3 by 2 by 3.1 centimeter heterogeneous nodule. And it was readily palpable on exam. The right lobe had no abnormalities seen. And her further workup included an FNA, and this showed cytology that was consistent with medullary thyroid cancer.
Peter, I'll interrupt for a second. So sorry, can you go back? So Brian, if this patient was seen in your clinic with an FNA showing medullary thyroid cancer, what would your additional workup be, including labs?
So certainly we would want to know what the calcitonin level was, because a calcitonin level that's in excess of a few hundred is going to be consistent with distant metastatic disease as opposed to just local regional disease. We certainly want to know the status of her cervical lymph nodes, so a detailed mapping ultrasound scan of her lateral neck and a CT scan in addition to that to look at both lateral and central neck would be key. We would run that CT scan down through the chest as well with an nodule of this size, the likelihood of distant metastases is relatively high, and the likelihood of nodal metastases is almost certain. So all of those things would be essential for us to move this forward. In addition, preoperatively, of course, we would want to exclude familial disease, and so we would screen for pheochromocytoma and hypoparathyroidism, and we would submit genetic testing for germline mutations.
So Yuri, based on this FNA, what other sort of molecular testing would you do and germline testing?
In contrast to cancer, to follicular self-derived cancers, as we discussed before, John's case, in medullary carcinoma, we do not really look for broad panels because most of them have RET gene mutation. So typically genetic testing is limited to a RET mutation. And if this is not found, then the reason it's open doors for broader testing. But RET mutation testing is the first one that is typically indicated in this case.
Thank you. Please continue, Peter.
Sure. So the calcitonin was markedly elevated, 4,599, the upper limit of normal being less than or equal to 7.6 in our lab. The CEA level was also elevated at 198.8, and again, upper limit of normal is 3.4. We did check a calcium level, and that was in the normal range. Similarly, PTH was high normal, but certainly normal, and the calcium was on the lower side. We did check plasma metanephrines, and those were all within normal limits, so there was no evidence of a pheochromocytoma. So additional workup, as Dr. McIver mentioned, we did lymph node mapping ultrasound, and there was in fact no lymphadenopathy in levels 1 through 6. CT scan of the neck showed no enlarged lymph nodes. She similarly had a CT of the chest that showed no suspicious lesions. And, you know, my preference is to also scan through the abdomen and pelvis to look for distant disease, for example, miliary spread to the liver, that sort of thing, especially with such a high calcitonin level, and that was also negative. And she ultimately did have RET testing, and that was also negative. So at that point,
One second, Peter. Sorry,
Sure.
I'll interrupt. So Greg and Joe, John, Mark, and I are probably not old enough, but what would you have done 20 years ago for this? Greg?
Well, I mean, you know, I think you have to, you're still going for a cure. I mean, that calcitonin level is too high to expect it's going to go to 0 and stay there. And I would tell the patient that. But I don't see any reason why, you know, I mean, everything that you've looked for is negative. And I mean, I've had higher calcitonin 0 out. It's possible. Whether you have nodes or not, I mean, all of this calcitonin may be a very hypersecreting isolated nodule, or there may be nodes also contributing to that calcitonin. In general, I've been of the flavor, and I know Mark doesn't follow this, of doing an ipsilateral lateral neck empirically as part of the central neck for this sort of surgery, and some of his work and others have shown that you can maybe forego that if the neck is radiographically N0, but I would do a lateral neck, bilateral central neck total thyroidectomy and counsel the patient that, you know, there might well be, we expect there would be microscopic distant metastatic disease that will prevent the calcitonin from zeroing out, and then give it my shot.
Brian, I think you have a comment.
Yeah, so there's something a little bit unusual about this because you have a large tumor, medullary thyroid cancer in the thyroid. The nodes are negative. The imaging is negative. We're missing something because that level of calcitonin and CEA is consistent with distant metastatic disease. So, you know, I'm going out on a limb because I've not seen this case before. I deliberately did not look at the slides, but I'm concerned that this may be a RAS-driven medullary thyroid cancer, and that the metastases are atypical and that they're in the in the skeletal system. So these could easily be bone metastases, but we're certainly not going to cure this patient again with surgery. I think surgery is important for local regional control, but curative intent is unlikely to be effective, I would argue.
Great. There are a couple of questions and comments. Lisa, I think, again, there's some controversy about the lateral neck, and I think Peter will point this out at the end of the presentation, so we'll save
Oh,
that.
hi, Ellie. No,
Go
that's
ahead.
okay. We're just having an endocrine section webinar.
Okay, shall I proceed?
Yes, please, Peter.
Sure.
Okay.
Sure.
So we planned an operation, and what was clear was that the patient would need a total thyroidectomy with a central node dissection. But there was certainly controversy about whether to do any further, like an ipsilateral lateral neck dissection. My preference is not to do that when there is no imaging to suggest that there's something there, because if I don't go into the lateral neck, I can always go back another day, and it's not it's not an operated field. So the pathology, in fact, showed a medullary thyroid carcinoma, which was interestingly bilateral, 4.1 centimeters in the left lobe and 0.2 centimeters in the right lobe, which is certainly suggestive of the potential for familial disease, although the RET testing was negative. And 10 lymph nodes from level 6 were all negative. So this was a PT3N0. And 6 weeks post-op, the calcitonin was less than 5. And the CEA was, interestingly enough, still elevated, although not, it started out about 200, so it was significantly lower. So 6 months post-op, the calcitonin remains undetectable.
Peter, before we go to the next slide, there's some questions about the role of FDG PET versus PET DOPA. Brian, do you have any thoughts on this, on preoperative imaging, in addition to the CT neck, chest, abdomen that Peter obtained?
So gadolinium dotatate PET is certainly far more sensitive than a traditional PET scan in metastatic medullary thyroid cancer. We have to remember that this is a neuroendocrine tumor, and we need to be thinking, again, like neuroendocrine folks rather than thyroid folks around this. The challenge with gadolinium dotatate PET is it's very expensive. Insurance companies hate to cover it, and so sometimes we default to traditional FDG PET. But FDG PET is insensitive in this disease. We may easily miss disease with that approach. Having said that, we have the backup of calcitonin CEA tracking. We have traditional cross-sectional imaging, and I would only really use an FDG PET scan if everything else is negative and the PET and the calcitonin continues to rise progressively and inexorably.
Yuri, Mike Singer's asking in the Q&A, if the patient was RET positive, are there certain mutations that warrant or that suggest a more aggressive behavior?
So
Yes.
I want to make a distinction, if I can, I want to make a distinction between germline testing and somatic mutation testing. And I know, Yuri, you'll be able to address this in much more informed detail. But if the RET mutation is germline testing, then obviously the 918 mutation is suggestive of MEN2B, which is a different disease than MEN2A. When it comes to somatic testing, the 918 mutation is the most common mutation in this sporadic medullary thyroid cancers. Yuri, over to you.
Yes, I want to say that overall, this case is very unusual. It's something here that I've been doing pathology for more than 20 years. It's a very strange case. It's a bilateral medullary carcinoma in a relatively young patient, and yet, I mean, it's negative for germline testing. To Brian's point, I would absolutely strongly recommend to do somatic testing on the tumor. for not only, first of all, it's a good question about the prognostication, because we know that 918 mutations are most aggressive of all MTCs, but even to further explore possibility of familial disease. First of all, I would like to know in pathology report, is there also C-cell hyperplasia? Because if this patient has C-cell hyperplasia and bilateral medullary carcinomas, that's basically familial disease until proven otherwise.
Yeah,
so I
that
think
was,
it's a, what did
I'm
you say?
sorry. The C-cell hyperplasia was not seen in the pathology.
Okay, that's better. That's suggest maybe that's one of the 1 in 1,000 cases where there is a bilateral disease without. But still, I would do somatic testing to Brian's point, little bit for prognostication, but also to have another layer of evidence in favor of familial or sporadic disease.
Yuri, can I just ask a question? This is, we now know what this is. It's a large, highly differentiated, highly secreting, non-metastatic medulla, at least for the first 6 months. We'll see long term. But I mean, this is a well-behaved, well-differentiated, highly secreting tumor. Is there anything pathologically that you can look at to get a sense of that?
You probably can look at the invasive margin, because we know medullary carcinoma come in all possible shapes and forms, and tumors that are infiltrative typically are earlier in giving metastasis. Tumors that still have very smooth, almost encapsulated borders, they are not. Beyond that, there is no size. It's probably a lymph node mets. This is probably pathologically what we look for in medullary carcinomas. But I want to say again that I would do somatic testing, and if this is a red mutation, then I would retest the blood to be sure that this red mutation is not present in the blood. If it's not the red mutation, then we know that beyond any doubt that this is not a familial disease and a somatic disease. Now, in terms of the aggressiveness, I mean, this is also now there is very good publication from MD Anderson and other places. So M918T is the most aggressive, then RAS tumors are kind of intermediate, and other type of red mutations, they are really sort of, on the bottom of spectrum of aggressiveness. With this presentation and no lymph nodes, no distant mets, maybe this is one of this least aggressive type of red mutation.
Brian, do you want to make a comment? And then we'll quickly move on to Peter's last slide.
Yeah, I just want to really reiterate the fact that the point that Yuri made, that this is a very unusual medullary thyroid cancer. To reach this size with no nodal metastases, a calcitonin that's elevated so high, and yet no imaging information to suggest distant mets, is a very bizarre one. And for that reason alone, I think that somatic mutation testing is really critical, if nothing else, to advance our understanding of the disease. But again, I worry about bone metastatic disease in this setting, because the traditional RET-driven medullary thyroid cancers, they tend to be hepatocentric, whereas the other ones are often skeletal-centric.
Thanks, Brian. Go ahead, Peter.
Thanks for those excellent comments. So, I think for me, this really raised the question of how we ought to manage lateral neck nodes. And certainly the ATA MTC guidelines do address this. And obviously it's a long document, and just a couple things to point out. From this document 2015, the recommendation was patients with MTC and no evidence of neck lymph node metastases by ultrasound, and no evidence of distant metastases should have a total thyroidectomy and dissection of lymph nodes in the central compartment, which is what we did. And that patients with MTC and no evidence of neck metastases on ultrasound, no distant mets, dissection of lymph nodes in the lateral compartment, so an ipsilateral lateral neck dissection may be considered based on serum calcitonin levels. And the task force did not achieve consensus on this recommendation. And I would say, again, this is really the question of how aggressive ought one be in the lateral neck. And it seems to me that we ought to always be aggressive in the central neck, because we don't want to have to go back. But when there's no evidence of disease in the lateral neck, I'm not sure it makes sense to be ultra aggressive without identifiable disease, given how good our imaging is these days. And, you know, at this point, the patient's in good shape, calcitonin is normal. If it starts rising and we have to go back, it'll be a first-time operation in that lateral neck. So.
Thank you so much, Peter. Mark, I think you want to make a comment, then we'll move to our third case.
Oh, yeah, I think that was a great case and great illustration of a controversy in medullary thyroid carcinoma, as Peter suggested with regard to the lateral neck. I just wanted to mention several studies have been published on this over the last 5 years. We published a paper about 3 years ago that we took patients who were observed in the presence of ultrasonographically and CT negative necks versus those who had an elective lateral neck dissection, and did not see any difference in biochemical cure, in survival, in ultimate local regional control, any of those things. So, and then I think Memorial Sloan Kettering subsequently has published something as well on that. So, which with similar findings. So I think at least the recent data I've seen would agree with that it's not necessarily needed to do a lateral neck dissection, and you can certainly always salvage these patients with a lateral neck dissection later.
Thank you. So our last final presenter is Dr. Joe Sharp from the Cleveland Clinic, who will present a case on anaplastic thyroid cancer.
Thank you. I'd like to thank Drs. Randolph, Stack, and Agrawal for the opportunity to speak. It's been a wonderful opportunity to see so many friends, and congratulations on the whole webinar series. It's really been a great series. Are the slides sharing there with everybody?
Yes.
Great. All right. So this is a 63-year-old patient, 1 month history of an enlarging right neck mass. She had some difficulty swallowing pills and solid food, no voice issues. She was awoken at the night with shortness of breath, no hoarseness, no neck pain. She did have a significant history of breast cancer, pathologic T1B, treated the year prior with surgery and radiation. The profile of the tumor is there. The patient had a history also of diabetes, hypertension, vitamin D deficiency. On her family history, it was non-contributory for any head and neck ailments, no history of radiation to the neck. And on her examination, she had a 5-centimeter right thyroid mass, no lymphadenopathy, normal vocal cord motion on fiber optic endoscopy. These are her films. On the top are her cross-sectional imaging with a CT scan. I agreed with the interpretation of the 3 by 2.9 by 4.2 centimeter right neck mass. No pathologic lymphadenopathy was seen. Ultrasound was done. Our radiologists are just like other centers. They refer to themselves all the times, but we do our own ultrasound. So they recommend an ultrasound. We did it. That is the transverse and sagittal views of the thyroid mass on the right side. She underwent an FNA of the mass. It was actually positive for malignant cells. The cytomorphology favored breast carcinoma with the support below for their diagnosis. I talked to her primary team, who was a bit incredulous that it could be a breast cancer, given how well she had been done. Although we did publish a series, John Russell was our primary author when he's a resident, on metastasis to the thyroid, and we have seen breast mets to the thyroid.
Joe, 1 second. So
Yeah.
Yuri, why would this be confused for thyroid breast cancer? Any thoughts on this? I know it's a long comment there, and I don't know if you had a chance to look at the case previously.
Well, I mean, I can tell you that morphologically, if tumor loses ability to make follicles, they're not so much different morphologically. So I would not be, it's not kind of shocking that they started that in a patient with a history of breast cancer, you start suspecting possibility of breast. But typically, if you have sufficient material, typically immunostains will help. You run a panel that's characteristic of breast, run panels that characteristic for thyroid, and typically it helps to differentiate both.
Great. Because of her history and some of the uncertainty, we did get a PET scan on her. It showed only the intensely hypermetabolic focus in that right thyroid that was suspicious for a neoplastic process. The rest of her examination was pretty unremarkable. She was discussed at our thyroid and then a separate multidisciplinary tumor board with surgery being recommended. She was consented for multiple possibilities, including a thyroid lobectomy, possible total thyroidectomy, possible central neck dissection. She underwent the surgery without any complication. I removed it, and I don't often do this, but I did run a frozen on it, and they were most suspicious that it was a metastasis. It was malignant, but they couldn't tell me much more intraoperatively at that point in time. And so at that point in time, given the concern that this might have been a metastasis that they were favoring, I held off on further surgery. About a week later, the pathology came back, and this is her actual report, which showed foci of undifferentiated anaplastic thyroid cancer rising in papillary thyroid cancer with predominantly poorly differentiated component. There were other nodules of papillary thyroid cancer present. One lymph node was negative for neoplasm, no parathyroid. The margins were close, about 1 millimeter, but the nodule, the carcinoma was not right at the edge. And so really about one of the most favorable anaplastics that you can ever imagine. However, you know, I put this in for the purpose because the maybe the weight of the decisions going forward are pretty heavy, as we're looking for a curative process for this patient. In our own center, we immediately asked for some addendums, and so we were able to get immunohistochemistry for BRAF. We usually can do that in about 1 day, and it was negative. We also asked for PD-L1, and they did not have any interpretation standards, so they held off on this. And so that kind of left us with some more information about
Do you
it.
mind if I interrupt you for a second?
Sure,
A couple
absolutely.
questions about the role of frozen section.
Yeah.
So Mark, what do you send frozens for thyroid lobectomies?
Very rarely. Typically, you know, I think frozen sections, I should say frozen sections of the thyroid are not particularly usually very helpful in terms of, you know, if you're looking at, you know, an indeterminate, you know, follicular neoplasm or Hürthle cell neoplasm, you're not going to be able to make the diagnosis of cancer based on a frozen section typically. The times that I use frozen section are typically when evaluating lymph nodes, because then it's pretty straightforward. But I rarely use frozen section for the thyroid, because you typically don't get information that's going to change your surgery.
And Yuri, do you get annoyed when we send the lobectomy for frozen section? How do you manage that?
Yeah, well, you know, our pathologists don't like very much to do frozen sections, you know. They're kind of getting spoiled now because our surgeons rarely send it. But I mean, typically, I mean, if diagnosis is not clear, it seems to me that this was preoperatively clear. It's cancer. If it's cancer, non-cancer, that's probably could be an indication. So, yeah, we do it when you need it.
Brian, you have a comment?
Yeah, so frozen section was invented at Mayo Clinic because the average temperature in the winter is 20 degrees below zero, and they were able to stick the specimen out of the window, flash freeze it, and then bring it in and analyze it. And for many, many years at Mayo, the standard of care was that every pathologic specimen had a frozen section. We analyzed those data for thyroid, you know, on multiple occasions, and demonstrated that there is some, you know, diagnostic benefit frozen section in follicular pattern thyroid lesions, but they are few and far between. And at the end of the day, it didn't really augment any of the kind of surgical findings. And so I know that Mayo has stopped doing frozen section on the majority of their follicular patterned thyroid nodules. I think the value of that is very marginal indeed.
This is Yuri. If I may, I just want to make a very quick comment about the pathology report. I would want to see the proportion of anaplastic carcinoma. I mean, the current guidelines and ATC guidelines that practically finalized, they're coming out very soon, will sort of specifically talk about it, because prognosis in anaplastic carcinomas in significant part would depend how large is the proportion of anaplastic carcinoma over better differentiated cancer. I wish that, I mean, I think pathologists should really specify this.
Yuri, since you're still talking, there's a question about cell-free DNA. Is any role of that in thyroid cancer in general or anaplastic cancer specifically?
Very limited. I mean, very limited. There are some work again from MD Anderson on the medullary carcinoma monitoring disease, but as a primary diagnostic tool, very, very early. We need really here a good molecular large panel on this tumor.
Sorry, Joe, go ahead, please.
Okay. And so a lot of questions to certainly talk about. We use the immunohistochemistry. We've had some discordance when we do our own molecular testing. I'd be interested to know from the panel if you're okay with treating, if this was BRAF positive, just with immunohistochemistry, and maybe where people would go for options with this type of case. It generated a lot of discussion at our center.
So, Mark, if you had a BRAF mutation anaplastic preoperatively on FNA or core, how would you have managed this case?
Well, this is as was mentioned by Dr. Sharp. This is an unusual anaplastic thyroid cancer presentation because it's confined to the thyroid. This is a stage 4A anaplastic thyroid cancer, essentially, which is again very, very rare. Typically, they present much later because of their rapid growth rate and with either significant extrathyroidal extension and/or distant metastasis. So. But if this was even with the BRAF mutation, I mean, it's confined to the thyroid. So probably if it's resectable and without much morbidity, which in this case, there wasn't really any significant degree of extrathyroidal extension, we would do surgery and then post-op chemoradiation. So because you have a chance to cure this patient with just local therapy. Probably would not treat this patient with systemic therapy, given the tumor confined to the thyroid gland.
And then Brendan asked, would you have done an upfront total if you knew that this was anaplastic with BRAF mutation, with a BRAF mutation?
I would not have. I just would have done the lobectomy. I wouldn't have seen any advantage in this case to doing. If you knew it was the anaplastic, you're not going to be giving the patient radioactive iodine anyway. So I think a lobectomy in that case would have been appropriate.
Brian, you have a comment, and then we'll continue with Joe's presentation.
Yeah, so I do think what Mark is saying is accurate. That the purpose of a total thyroidectomy and unilateral disease is just free the way for radioactive iodine. Anaplastic thyroid cancer does not have really any role to play in the management of anaplastic thyroid cancer. So you want to clear the disease, manage the local regional disease, and then clear the way for the systemic therapy. Because these patients are, even though this is contained cancer that is apparently surgically completely resected, the majority of these patients die of distant metastatic disease. And our study from the late 1990s really confirmed that irrespective of whether you're stage 4A, 4B, or 4C, the mortality rate is still exceptionally high in this disease. So looking for the distant metastases and then being willing to treat aggressively, and in this case, this is where immunotherapy may well have a role to play. I think that we need to think about that. The tumor mutational burden is very high. Neoantigens are likely presented here. There's a great clinical trial going on right now, open at MD Anderson and probably several other sites of immunotherapy for anaplastic thyroid cancer that is BRAF negative. And I think, again, this patient should be considered for referral to that at the moment she has any evidence of recurrent disease.
Please continue, Joe. Thank you.
So we sent it for further testing. This comes back a bit later, the Tempest testing. We discussed it at the multidisciplinary tumor board, and arguably this is not a pathology you'd want in your neck. And like I said, this is something kind of weighed on us to try to figure out the best idea for treatment for cure. Had it been positive, we probably would have given her dabrafimib and trametinib. Would the rest of the panel probably agree with that if it was positive for BRAF?
So maybe I can comment. I think it would be appropriate if there was evidence of persistent disease, but treating
Okay.
without evidence of disease is a little more marginal.
Marginal, okay. All right. Okay, so we ended up, for this patient who is BRAF negative, she actually got treated with radiation and paclitaxel, carboplatin. 3 months afterwards, she's looked good. We had some further discussions, whether or not to pursue further surgery, engage her in some of those decisions. She's held off on wanting surgery. At about 9 months post-treatment, she's continued to look good on imaging. But I guess at this point, would anyone offer further surgery or just continue to watch this situation? She hasn't shown any evidence yet.
Yeah, Mark, if you have any comments, and then I think there's some question about adjuvant treatment, especially radiation versus chemoradiation, and how this is different than the first case. But Mark, any comment on Joe's question?
I think the question, I guess that there are two different questions. The question from Joe was whether there would be a role for further surgery, correct?
Yeah,
Yes.
no one role.
And I wouldn't see a role. I mean, the patient doesn't have any evidence of disease. Is that correct?
That's correct. These are 9
yeah.
month post-treatment.
So no, I wouldn't see any role for this patient. I'm assuming got post-op chemo XRT.
Yeah, she got, once again, it was paclitaxel, carboplatin, 5
Yeah,
cycles.
yeah. So patient already received post-op chemo XRT. The patient may be cured. Of course, patient could present with distant metastasis, as was mentioned, high risk for that, but I wouldn't recommend any other treatment at this point. I think the difference, to answer the second question, the difference between, this type of patient in that PTC patient that was presented earlier is really the biology of the disease. The biology of that, the biology of anaplastic cancer is well known to be, one of the most aggressive cancers in humans. So when you have a chance for a cure, which you do in this patient, because this patient has no distant disease, you want to maximize that chance, and so you maximize the local regional therapy in order to try to give that patient a cure. Whereas the other patient was a patient who, while biologically aggressive potentially for PTC, is not on the level of aggressivity as you would see with the anaplastic thyroid cancer. And so, and also that patient had distant disease, and so you're not going to maximize the local regional therapy and maximize the morbidity of the local regional therapy when you're going to be treating the patient for distant disease anyway, and that's really going to be the focus following the surgery. So I think that's the difference between those two cases in my mind.
This is Yuri. If I may make a quick comment about the results of molecular testing, Dr. Sharp, can you go back to the report? Want to stress a couple questions. One, this is a screening signature of highly aggressive cancer. You have early mutations like P10, you have late mutations, TP53, you have ATRX mutation. This is a bad tumor. Unfortunately, the clinical team should be prepared that this tumor manifests again. It would be exceedingly unlikely that this patient is cured from this disease. Second point I want to make, kind of sort of good news for the patient. Patient has a mutation, tumor has mutation in MSH2 gene. This is one of the DNA repair enzymes. So there may be patient with high level of microsatellite instability, and TMB is high, 88th percentile. I think with this profile, I think that we really need to think about immunotherapy as a possible option for this patient.
We wanted to be far ahead on this patient just for those reasons. That's why we tried to get as much information as we can on this to be prepared if we run that situation.
Thank you so much, Joe. I want to thank Mike, Brendan, Greg, our discussants, Yuri, Brian, Mark, and our presenters, John, Peter, and Joe, for a great discussion. I'm going to turn it over to Greg Randolph to close. You're muted, Greg.
In addition to thanking our wonderful discussants, Brian and Yuri and Mark, all of our wonderful presenters, Joe and Peter and John, we really thank their time and expertise on behalf of all of our attendees. Our next webinar is especially interesting one, which is the presentation of the joint Head and Neck Society ACE Pediatric Thyroid Cancer Consensus Statement, and will be chaired by Brendan Stack and Christine Twinning, its co-chairs. And so we'll be reviewing pediatric thyroid cancer at length. Thank you very much. And Nishant, I think we all thank you for all of your work and leadership in putting together this wonderful program. Thank you so much, Nishant.
Thank you all. No, this is an easy job, and thank you, Betty, for all the administrative help. Thank you all. Have a good night.
My pleasure. Thank you.
Good night.
Bye.